I'm Sam Klempner. I'm a GI medical oncologist at Mass General in Boston. Thank you to everybody for joining. This is the first of many Debbie's Dream Foundation Doctors on Call webinars where essentially the goal is to really provide a forum for you to ask any questions about gastroesophageal cancers. These can be things that are on your mind, future directions of treatment, things you've heard. We want this to be a very interactive forum. We will have a little bit of guided discussion because there was just a conference, ASCO GI, and talk a little bit about updates. I'm joined tonight by two other GI oncologists who I'll let them introduce themselves in a second. But yeah, Mike, why don't you go ahead?
Sure, no, my pleasure. It's great to be here. I'm Mike Cusnir. I'm the division chief at Mount Sinai Medical Center over in Miami Beach, Florida, mostly dedicated to GI oncology, as Sam said, and it's a pleasure to be here as part of the panel.
Welcome. It's good to see you. I'm jealous of your Miami location a little bit, but Rutika and I are up in the Northeast, so Rutika, feel free to introduce yourself.
It feels great to be here today. My name is Rutika Mehta. I'm a GI medical oncologist as well. I practice at Weill Cornell Medicine, New York Presbyterian, New York City. My focus has been primarily gastroesophageal cancers, and I've been in practice for over 7 years now.
Awesome. So experienced panel of people. You can put questions in the chat. In addition, we wanted to include a few polls. Really, the reason for that is we want to understand the audience as best as possible so that we can serve you guys with topics and things that are really of interest. You know, if nobody's interested in talking about H. pylori, like we don't need to spend time talking about it. So there will be some polls. In fact, feel free to put in the chat where you're calling in from, or actually, can we lead off with the first poll? Yes, this is just a sense of where do you stand in your treatment, and maybe you're not a patient, maybe you're a caregiver, maybe you're a child of a patient, etc. But if you have the ability, please feel free to give yourself, oh, here it popped up already. Give yourself a few seconds to answer this. All right, so about 2/3 of people are in the first line of therapy. That's great. That is where we generally have the most options, and so there's a great place for discussion. And then a smattering of people across different lines of therapy, surveillance, newly diagnosed, etc. So great. We have topics to sort of hopefully address all of these areas of therapy. In fact, maybe if we go to the next slide to talk a little bit about the outline. So I'm going to stop talking in a second, and I'm going to ask Mike and Rutika about what they thought were sort of therapies that they're keeping an eye on that are of interest to you, and then share any data from ASCO GI that you thought was interesting or might be relevant to the stomach cancer community. So, Mike, I'll start with you. What kind of areas, could be anything, targets, etc., are you kind of interested in?
Also, it's been an exciting few years for gastric cancer because after many years of not having much, I would say, new news to report, we're finally starting to see a little bit of a splitting of the hairs in gastric cancer, getting some new target therapies. Obviously, gastric cancer is ahead of a lot of the other GI malignancies of looking at immunotherapy. So even getting the new immunotherapies to be more active, it's been very exciting. So I think that we are probably getting to the beginning of a new era in gastric cancer, that it's going to start to be looking at a lot of different options for our patients and not just a handful of therapies.
Yeah, totally agree. I think there's you know, immunotherapy, maybe even in the non-metastatic setting, if some of these studies are positive, maybe later this year or ASCO or ESMO, or we'll see. Rutika, what about you? Same question, sort of areas that are of interest to you, or anything that ASCO GI kind of brought forward?
Um, Not so much within targeted therapies, but there was a trial that was presented by our Asian colleagues about chemotherapy with intraperitoneal chemotherapy for metastatic gastric cancers, and that seemed to show an improvement in survival for these patients. Now, intraperitoneal chemotherapy as opposed to HIPEC or PIPEC, so those are the newer forms of administration of chemotherapy within the peritoneum. So I don't know how much relevant that is in the age where a lot of our surgeons are leaning more and more towards HIPEC and PIPEC, which are the newer technologies. Moreover, the chemotherapy used in those trials were kind of not something that we use in the US at this point in time. They were not targeted based therapies, did not include immunotherapy. So, how much we could put that into context with current practice is still unknown. But it's reassuring to see that more and more intraperitoneal based therapies are seeming to show benefit in our subset of patients.
Yeah, I totally agree. It's certainly a population of patients, and a common question in forums and support groups. What do I do about my peritoneal disease, or is there anything that can be done? And at least people are paying more and more attention to this problem, and hopefully we'll get more and more data. I agree. I think ASCO GI, we are seeing some clues about maybe some new strategies to hit some of these targets. I thought that Aspen trial of like a quadruplet regimen in the second line for HER2 positive is interesting. So for those listening, this was basically taking a standard second line therapy, so the second chemo that usually you get, and adding like 2 new drugs essentially onto it. So usually it's 2 drugs, and they made it 4 drugs, and the tumor shrinkage rate was better than what we expect for normal chemotherapy. Sorry, I have a light that's falling apart. And it's interesting because it's just gives us clues that we can push and improve upon some of these pathways. I want to make sure we get to questions, so please do feel free to write into the chat, or as I said, you can ask to be put onto the stage like this where you're seeing all of us, and we'll see you too if you want to have a question. There were a couple questions that came in ahead of time, and I'm going to get through a couple of them to our panelists. And one of them, which is a common question, has to do with sort of life after surgery. And Mike, I'll start with you. What's sort of your 2-minute in the office discussion of, here's what to expect after a gastrectomy? Obviously, it's not a one-time discussion. This is a lifelong change, but how do you sort of lay it out typically?
Yeah, so I have a little bit of an extra background that I usually don't, that a lot of times doesn't come up in a lot of these discussions, but I also studied for 2 years all the integrative therapies. That part of what we study and all that is nutrition. And that's been a topic of big level interest for me, because a lot of times people underestimate the amount of function of the stomach. Everybody thinks that the stomach is just a big pouch, that it just receives everything that we put in our mouths and distributes to the rest of the body in a hourglass type of thing, and much slower. But the amount of absorption of nutrients and the amount of functionality that the stomach has from many other points of view is quite important. So I actually do spend quite a bit of time with the patients talking about nutrition from multiple levels, which I think that it's important. And one of it is just the surgery effect of the nutrients that the person can expect to require to be supplemented after a gastrectomy, even to the point of the effects of the rapid transit of things in the intestinal tract, from the dumping syndrome and all that. That being said, most of the patients tend to ask me much more is of what can they do to improve their health with the nutrition, which I do think that it's a topic that we are all interested in. It's an not well studied topic, and the patients do ask us if they need to be radical in changing their diet and all that. In a lot of the other GI malignancies, we don't have that much information, but with gastric cancer, the change in nutrition is very, very important. So that's something that everybody needs to be with a big team, dietitian, and all that. So that's super important.
Yeah, totally agree. And Rutika, I'll ask you this version of the question, like, what do you usually tell people the average time to sort of settle into a new normal? Because you never quite get back to what you were exactly before surgery.
That's true. I think it depends differently for patients who've had a subtotal gastrectomy or distal gastrectomy versus a total gastrectomy. Patients who've had a distal or a subtotal find it relatively sooner to recover. Still, they would take about 6 months or so. For patients who undergo a total gastrectomy, it could take as long as up to a year to start to feel like they're feeling normal again, or normalcy is starting to return. So I try to reassure my patients, give it that much time. And I agree with Mike. I think diet is very important. Nutrition is extremely important. It is, since they do not have a stomach, especially after total gastrectomy, feeling hungry is not a common symptom that they will experience. So I usually tell my patients to set an alarm on their phone to remind them every 2 to 3 hours to at least put something into them so that they are nutritionally sound.
Yeah, I agree. It's like a part-time job, uh, to, to, to recover from a total gastrectomy and subtotal as well. Yeah, I completely agree. I always ask patients, as they get like a year or two out from the surgery, when did you kind of settle in? And it's all over the map. I heard people 3 months, 6 months, 10 months, everything clicked at month 9. So I think always worth to keep trying. Well, so as a little bit of background, zolbetuximab, which is a Claudin 18 directed antibody for like the 40% of people that have Claudin 18 in their stomach tumors, is approved in combination with FOLFOX or CAPOX chemotherapy. But many people had already started on chemotherapy before they had their Claudin result or before the approval happened in October. And so Christina's question is something that many people come into clinic, and I'm sure both of you have had this experience, but I'll read it briefly for those listening. Essentially, Christina is a young woman who has signet ring cell gastric cancer, very recent diagnosis, tolerating FOLFOX pretty well, and recently found to be 100% Claudin 18.2 positive, HER2 and PD-L1 negative. So I'll address the first part of the question to you, Rutika, first. So in this situation, what are sort of your thoughts, or how do you think through about whether or not to add zolbetuximab?
Yeah, I mean, in real case scenario, I rarely get all the biomarkers before someone starts chemotherapy. So it's quite frequent that I've started them on chemotherapy, and then after 2 or 3 cycles, when the biomarker results have come back, I have added on the targeted therapy. So based on our 2 recent positive trials and thereby the FDA approval of chemotherapy plus zolbetuximab, um, pending no other contraindications to that therapy, I would suggest considering FOLFOX plus zolbetuximab. The question is also about FLOT plus zolbetuximab. I don't think so. We have safety data for that at this point in time. So I would still keep the FOLFOX with the zolbetuximab.
And what about you, Mike? How are you thinking through this scenario?
Yeah, the same, and this is one of those situations that the patients do feel compelled to try to throw as much at them in the beginning, and we always remind the patients that we're here to run the marathon and not the 100-meter dash. So definitely, I tend to agree with Rutika that's what we need to do. We need to take it slow and do not create too much toxicity in the beginning, and that's the one that has been most widely studied, much more than the triplet.
Yeah,
I think it's important to tell the group, if not everybody knows the difference in between what FOLFOX and FLOT are. Just to clarify, if a lot of times we tend to speak as doctors and forget that the patients in the audience may not remember, but one is a 2 chemotherapy regimen, the other one is a 3 chemotherapy regimen, and then the other question was to add the targeted agent, the Claudin 18.2. Yeah.
Yeah, I would agree with both of you and Christina. This is what I've done in my own practice is people in your scenario, I have commonly added or offered to add zolbetuximab. Especially, you mentioned your goal to ultimately get to consideration for some of these aggressive surgical approaches. And, being aggressive would include adding zolbetuximab, in my opinion, in this scenario. So definitely worth an ongoing discussion with your local team. All right, Orit, I see your question. You guys are right on. Well, actually, let's get this one first, and I'll come to you, Mike. It's about essentially early onset gastric cancer, and I mean, I'm not going to ask you to solve this one because I don't think any of us know the answer yet, but talk a little bit about, are there populations that you think we need to maybe screen, maybe, make sure that the word is getting out there in the community?
Yeah, this is something that it's interesting because this has been a topic that when uh, even my current nurse practitioner that was working with me at some point, she said like, how come that with the gastroenterologists when they screen for colon cancer, they just don't throw in as an extra just to take a look at the stomach, like they're not doing much more to the patient, does not require any extra preparation. It's minimal amount of extra anesthesia time, and we even discussed it to throw it as a study of asking the question in our center to just throw in the scope in all the patients that were getting screening scopes for the colonoscopy, which it is a standard, when we don't have a standard for screening with gastric cancer. Now, I have to answer that a little bit also from the scientific point of view of when do we screen and when we do not screen. And this is something that it's not easy to talk to a population based when we tell them like we screen of things that we can impact on a higher level in early stage detection that will make an impact on a cost benefit ratio. So very complex type of formula, but it's tough. It's tough because we need to make choices sometimes in the medical field of when and why to screen. And now, unless that there is any type of genetic abnormality in the family or some other reason, there's no real screening. When we're talking about the screening, it means people with no symptoms. I saw a question pop in the chat earlier of somebody that has early satiety, bad heartburn, anything like that. That's not screening. Screening will mean take everybody over the age of 30 and throw a scope at them. And if it would be me, if I would be the one making policy, I would say, yes, let's do it. And then somebody smarter than me will say like, how often? And we don't have the answer. So that's sort of where we are. But it is something that now on the second part of the question of diet, lifestyle, and all that, this is something that we are as GI oncologists on the forefront of this because the big epidemic has been with colon cancer of looking at very young people, but we're seeing it in gastric cancer. Like I can tell you, probably it's the same for all of us that are in GI oncology. Not a single week goes by that I don't see somebody younger than the age of 50, when in the past it was a rarity. I've been in practice already for like over 23 years, and it was rare to see patients this young. I think that this is from not just early onset, but early causes. That maybe my generation that we used to love to go to McDonald's, and I'm sorry, I shouldn't talk to about brands or anything like that, but fast foods and foods that are not that healthy and things like that as kids when we're very, very young, that it was completely, it may be affecting us now. But I honestly don't have the answer. I have no idea.
Yeah, maybe I'll ask you similar, mostly about the diet and lifestyle. But first, what percent of GI oncologists do you think have had an upper GI endoscopy?
What percentage of what?
Upper GI oncologists like us have had an
Oh,
upper endoscopy.
so this is funny. I think it's super low, and the worst part is that even getting it covered, because that's part of the problem. The healthcare system just getting things covered when you are there and you tell, like I'm over the age of 45, so I'm already at my past my even my second colonoscopy, But every time I go for one, I insist that they also do an upper. And I have to claim that I had early reflux and things like that. And then it becomes non-screening, but kind of like a surveillance, which is different. But yeah, most of the GI oncologists don't have colonoscopies. We had a recent GI meeting in which somebody asked like everybody that is over the age of 45 stand up, and then he said like everybody that has not had a colonoscopy stay standing, and a bunch of GI oncologists stay standing. So that's sad.
Yeah, no, need to get the word out. Actually, Rutika, I'm going to give you other question because there's a bunch of questions popping in.
First, I wanted to say thank you so much for doing this meeting. This is excellent. My husband is on, and he was recently diagnosed with, it was stage 3 until they found teeny bit of scar tissue outside the stomach on the abdominal wall, and they tested and it was positive. So now he's stage 4. And we just got back from the oncologist a couple of hours ago. And what Christina asked earlier is similar to his situation, but his biomarkers were all 0, basically. He's not a candidate for immunotherapy, but they did give him those same 2 options. And I was still a little overwhelmed with all of the new terms that we're learning. I just wanted to understand, it sounded like all 3 of you said the same thing, to go with the second option, right? The FOLFOX, because they left the decision in our hands right now, basically.
So just let me ask a real quick clarification before I give it to Dr. Mehta. Your husband is positive for that marker, the claudin, or unknown?
No, and I do remember Claudin was one of them too, because his name is Claudio, ironically. But they said that all the biomarkers came back as 0, basically that he's not a candidate for any of the immunotherapies that they were thinking that he could, possibly do. So he's not going to be able to do immunotherapy unless something else is out there that he can do. But right now, the options that they gave him are basically those 2 that I don't even remember how to say them. And they were initially doing 4 rounds of chemo surgery and then 4 rounds of chemo again, the standard of care. And then when they found the small scar tissue that tested positive for cancer, they were going to take surgery completely off the table. But they said, because he's young, and sounds like what you're saying, that, he's 51, because he's young, he looks healthy, he might possibly do well with the original plan, which was the chemo surgery and chemo. They're not going to completely take surgery off the table. So they're going to do chemo first, see how he is, do another laparoscopy, diagnostic laparoscopic, and then chemo again. But they gave us this new thing where they said it would be more chemo, like three different medications. And at that point we were just like, okay, I'm not sure what any of this means. We're so new to all of this. He recently got diagnosed. It was just like a silent reflux. His symptoms were so silent, almost non-existent. And he called his gastro, and his gastro was like, you know what, come on in, let's take a look at this. And he had a tumor, like a third the size of his stomach.
Yeah, unfortunate, as Mike was mentioning, many patients unfortunately don't have a lot of symptoms, which is why we wonder about screening, of course. Rutika, tell us maybe a little bit how you think about selecting people for surgery with like oligometastatic disease.
Yeah, that's always a tough question to answer. So I think there are several considerations that we have to keep in mind. Number one, patient is young, healthy, no other comorbidities or no other medical issues that would compromise their candidacy for surgery. Having a surgeon on board to kind of vouch that there could be a surgical option. And that could include either, chemotherapy followed by a gastrectomy, or some surgeons like to be a little bit more cautious and they would kind of suggest do chemotherapy, come back for another laparoscopy. So there are certain criteria or certain questions that you could potentially pose with the surgeon if you have a chance to meet with the surgeon. Number one, what was the PCI, or the peritoneal carcinomatosis index, which means they give a scoring system based on how much cancer was identified within the abdominal cavity. And typically, if it's less than 6, most of the peritoneal surgeons would be okay to offer HIPEC. CRS stands for cytoreductive surgery, which means there is visible tumor deposits within the abdominal cavity. So they have to take those out along with injecting chemotherapy into the abdominal cavity. So that's the difference between those two. So CRS plus HIPEC means you're stripping off any cancer cells, visible cancer deposits within the peritoneum, and introducing chemotherapy to kind of wash the area, versus there is no visible tumor deposits and you are doing HIPEC, that is heated intraperitoneal chemotherapy, just as a means to kind of remove any microscopic cancer cells that could still be there. So typically, if you're less than 6 of a PCI and you've gotten several months of chemotherapy, you have a staging laparoscopy again, they will take some cytologies from within the peritoneum, which means inject some saline into the abdominal cavity. When that saline returns, they check it under the microscope, make sure there are no cancer cells. If there are no cancer cells, they would proceed with offering the surgery, with some surgeons like to offer the HIPEC as a protective mechanism.
Oh, awesome. Thank you so much. I'll definitely listen again to the recording and take notes later.
Okay.
Yeah,
Thank you so much.
And
I
in terms
agree.
of the chemotherapy, what we were talking about, a 2-drug chemotherapy that's ironically got a longer name, which is FOLFOX, FOLFOX, and a 3-drug chemotherapy regimen has a shorter name or a shorter acronym, which is FLOT. So again, if your husband is someone that is going to be planned for surgery in the near future, then a 3-drug regimen could be tolerable for a short period of time. But again, discuss what the long-term plan is going to be, short-term, long-term plan, what the intent would be of the treatment before proceeding.
Awesome. Thank you so much.
Yep.
And I wanted to add that I agree with Dr. Cusnir, who was saying about nutrition. And I am so thankful that my daughter, I don't know if she's still on, she is just finishing her master's in nutrition. She's going to be a registered dietitian. So she's really like on top of what he's eating. And she has agreed that nutrition is everything. Yeah.
You can probably have a job anywhere in the country. I heard
Mm.
that there's like one dietitian for every 7,000 cancer patients, or some crazy number, which is why it's so hard for us to get all of our patients to see dietitians. We would love to have everyone to have a dietitian, including myself, but that's just, the numbers don't work. Yeah, I agree with everything that Mike and Rutika said. I think the key question to the surgeon is like, can they get it all out? Do they think they can? Because if surgery doesn't usually help patients if it can't remove everything they can see. So if you know going in that, we're going to take out the stomach and 3 spots in the liver, but we can't get to the 4th one, that's not someone that we would almost ever think of recommending an operation for. But it sounds like you're in a very different situation. So that's good, because this also touches on clinical trials, which this is a clinical trial that's worth knowing out there. So it's about your husband who's attempting to join the phase 3 Clarity trial, which I'm happy to give an overview. So this is a Claudin positive study. So he's Claudin positive and also has ARID1A and pathogenic PALB2 mutations. One of the drug choices is apatinib. Mike, I know apatinib is actually not a choice in the US on the trial because it's not approved in the US. But Mike, maybe thoughts on the trial in general? It's, Claudin ADC versus standard of care chemo.
Yeah, so usually I always tell the patients that if the clinical trial does not close the door for something else, the clinical trial is always the answer, because all the drugs that are approved, you probably will be able to get later on as well. So getting a drug under a clinical trial just opens the door. And again, it's unfortunate that as much as on the opening statement we were saying that we do have quite a bit of drugs on development, we still have only a handful of drugs that are available for gastric cancer. So anything that you add into that armamentarium of getting more drugs, which includes the ones in clinical trial, it's always the answer. Apatinib is I don't even know if you can even get apatinib here in the States because it's a drug approved in China. It doesn't really address those mutations because it's an anti-angiogenic drug. similar to one that we do have approved in the United States, that is ramucirumab. But the truth is that there's some other drugs that will address PALB2 and ARID1. But I always feel that if you have the option to participate in a clinical trial, and this is a little bit altruistic to say it, but it's also true that I do believe in this, that you definitely will be helping future generations, because you also help us gaining knowledge about what's going to be better. That tomorrow, when I'm sitting with a patient and ask me, should I get this drug or the standard of care, I will answer that question with knowledge. But on the non-altruistic phase, on the selfish part of the patient, and I'm not trying to sound like a used car salesman to make people participate in clinical trials, most of the clinical trials will not close the door to an FDA approved alternative. Most,
Yeah.
I'll not say that all of them, but that's sort of the way that I go for it.
I think that's a very, very good point and message. Rutika, I'm going to ask you sort of general thoughts about other Claudin 18 strategies and maybe give a brief overview of what an ADC is.
So when we talk about targeting a protein or a gene, there could be different mechanisms by which we could do that. So zolbetuximab, which we had discussed previously, is a monoclonal antibody, which means it's a generated antibody that targets that certain protein without any added zaz to it. Then we have what we call as antibody drug conjugates, which means it's that same antibody or a similar antibody, but now it's connected with a linker to a chemotherapy-like drug. So therefore, it gives you the side effects of what a chemotherapy would essentially be like. You also have bispecific drugs, which means it can target two different targets, and those could be monoclonal antibodies. And then there's other Claudin agents called CAR-T treatments, which are much more elaborate. That means patient's blood is taken, it's been freezed for their T cells, which means you filter out your immune cells, send it to a manufacturer. They kind of generate the immune cells or re-engineer those immune cells to express the protein that the cancer cells are making. And then those are delivered back into the patient's body to be tried to kill the cells which are now expressing those proteins. Those are trickier trials. Those do require inpatient hospitalizations, and those are longer treatments. But that's kind of in a gist of what are the different mechanisms by which you can target a certain protein.
Yeah, totally agree. Those are very hot topics in gastric and other cancers. Actually, like even a few weeks ago, CarsGen, the CAR T company, announced that their randomized phase 2 trial was positive. So the CAR T cell beat chemotherapy for the first time in any solid tumor that I'm aware of, which is maybe even another option will be coming our way in the not too distant future. So your husband, 72-year-old, diagnosed in a year ago, January 2024, got FLOT surgery, adjuvant FLOT. Sounds like did really well. And then because of the pathology after that, completed 5FU and radiation for a close margin and a lot of lymph nodes, if I'm interpreting correctly. And then just had a PET CT Wednesday. Your question is about if something appears, new metastasis, what would be the first questions to ask? And Mike, I'll give you this, like, what are the common questions and people come to your office with a new diagnosis or recurrence that they should ask that they don't ask?
So I can tell you that the biggest question that patients should ask goes back to the clinical trial qualifications, that a lot of times we see patients with gastric cancer that have what we call non-measurable disease, meaning that they went to do the surgery and they found peritoneal nodules, and they sampled them and they were positive, and they decided to abort the surgery. And when the patient comes to my office, and I have a many of clinical trials, some of the clinical trials may not allow me to enroll So that's one question that you need to ask your oncologist. Do I have disease that can be seen anywhere else? Because that will be something big on pre-qualifications. The second thing is that, as you see also in your question, as the early development of the cancer, when there's an early stage, we don't look that much at all those what we call biomarkers, next generation sequencing, and a lot of stuff. But at the moment that we have more advanced disease, they become pivotal in our decision making. So you need to ask your oncologist, has the next generation sequencing and the molecular markers, they go by many, many names, has it been done? So that's sort of like the biggest two questions that a lot of times when I see patients in consultation, even from other institutions around, like here in Miami, we see quite a bit of patients, even from international locations, that they come and I have 10 to 15 days by the time that I see the patient before I can work because none of that has been answered. So that's super important that you start to line up that as you're going to seek a consult with somebody that it's a subspecialist.
So I'm going to ask you the same one, Rutika. So when you see new patients or newly recurrent patients, what are the things that you think that they should ask that, you know, sometimes are not asked?
So first and foremost, when I see a patient that has had poor response to pre-surgical treatment, I try to send off all the biomarker testing and the NGS testing preemptively. That's typically what I do. But otherwise, I agree with Mike. I think every patient should be asking what my biomarker statuses are, and that includes MMR, PD-L1, HER2, Claudin. These are your 4 common ones that you need to know about. And then rest others would be additional information for you to be able to explore other newer trials. So that's kind of my takeaway that I would tell my patients to do. If they, I mean, that's a routine question I get asked. What is something that we haven't asked, but we should have asked you?
Yeah, I think that's a common one as well. I would say that I think the NCCN, which is the National Comprehensive Cancer Network, which is basically where physicians can get guidelines, does a really good job on sort of the NCCN for patients, which is like a 25-page booklet of outlining the basics of stomach cancer. And also there's like at the last third of it, there's literally like 3 pages of 25 questions you should ask your oncologist or your surgeon. And they're actually really good. And I don't think the NCCN honestly does a great job of getting it out there as a resource. But that's the only thing I would add on top of what was said is that, you know, it's like nccn.org or .com or something like that. And there's guidelines for patients. And they're really good. They have one for esophagus cancer. They have them for all kinds of cancers, breast cancer, etc. And yes, I see Lucy is seconding our. So yeah, I think it's something that, you know, coming to places like this, you know, hopefully we'll all learn from each other about additional resources. I'm sure sometimes patients find stuff that I don't or we don't know about either.
I thank you so much for that. And I apologize for the lighting. I had to scramble back onto this call. My husband's oncologist just called with one of his reports from his cat and his PET scan. So seemed kind of important. I really appreciate the information. And thank you so much for recording this because I can listen to your answers when I see this online, and courtesy to the group. But you've answered many questions already. And I feel fairly good about the way we've handled his nutrition. We brought him up 25 pounds pre-surgically, and he had a large, bulky tumor. And for him to be able to bring his weight up by another 20 pounds, he's like 10 pounds overweight. We've kept him on and off his J-tube. And most recently, he's discontinued for 2 weeks, and he's managing to keep 2,000 calories down. So that was, I think that really was the key for us. That was probably number 1 for us.
Yeah.
As being prepared for this. I think that's probably why he was so well prepared for just the onslaught that he received. So thank you very much for your time.
Of course. No, thank you. All right, I'm going to come back to Rutika for this new question in the chat. So, 53-year-old going through treatment for stage 4 esophageal cancer, 14 rounds of FOLFOX, trastuzumab, and pembrolizumab or Keytruda. Really nice response and plan for a total gastrectomy. I'll let you ask a few questions, Rutika. I'm sure you have questions about where the disease was originally, etc. But the questions are chances of recurrence after surgery, and sort of, understanding that these are hard predictions to make.
Yeah, thanks, Sam. I think few questions to just help clarify would be when it was diagnosed as stage 4, number one, where was the site of the primary cancer? Are we talking about true esophagus or the GE junction, which is the junction between the esophagus and the stomach, or in the stomach? So that would be question number 1. And number 2 would be what was the site of stage 4 disease? Those are the 2 important questions that I would have to clarify.
The cancer originated in the junction where the stomach and the esophagus meet. The inside of the stomach, the lymph nodes right outside the stomach, I think was the metastasis. That's where it's been.
So just in the lymph nodes outside of the stomach is where the metastases was?
Yeah.
Okay. And they were just surrounding the tumor, correct? Nothing.
One of the lymph nodes blew up to about 2 inches and was leaning on my stomach and my pancreas. And that
Got
was cancerous, and the inside lining of my stomach and the junction where the esophagus and the stomach meet. But it responded really well to the treatments. I think the tumors were like adhering to like my spine and the pancreas, and that big lymph node was adhering to the stomach. But during the laparoscopy, it freed up everywhere and it shrunk so drastically much. The 2-inch tumor shrunk down to like half the size of a string bean. The esophageal junction cleared up completely, and the inside of the stomach lining is just about gone.
So when you talk about the inside of the stomach lining, you're talking about the abdominal cavity, correct?
Inside the stomach organ.
Okay. In this case, if the surgeons are taking you for surgery and they feel like they would get everything out, there would be no remaining cancer left behind. Your outcomes could be good. It's really hard to predict. It's still unclear to me, the extent of your tumor initially, but if you've had a great response for it's 14 treatments now, 14 rounds of FOLFOX
Yeah.
over 6 months. If you undergo surgery and it's a curative intent surgery, which means the surgeon is confident that anything cancerous has been taken out, you could have good outcomes. You'll still need monitoring. You still need routine follow-ups with your oncologist with blood work and CAT scans. And if there are any concerns, you would need a follow-up PET scan for that. But that ain't going away. That would have to be at least for the first 2 years, and then
Yeah, I've been monitored for the breast cancer. I had breast cancer 11 years ago.
got it.
This is my second cancer. They've been following me I think they're following me for life because I have the BRCA gene.
Got it.
So, lucky me. But yeah, surgery in 2 weeks. So I'm hoping for good outcomes, and no third cancer would be fabulous. That's my prayer.
Wish you all the best.
Thank you.
I agree that HER2 positive disease is often a different entity almost entirely. We do sometimes see exceptional responses and think about things like consolidation surgeries, like what sounds like you're describing. I don't know, there's variable practices, but even after surgery, we will often continue people on maybe the immunotherapy and the targeted therapy, with or without any chemo. A couple new questions came in. Mike, I'm going to give you this easy one about why chemo doesn't kill more cancers. But question is about plot. And yes, I have said, and it's based on phase 3 trials like the Matterhorn study, where we saw that only 7% of people had a complete pathologic response to FLOT. It's not that people don't respond to FLOT. I think what you're referring to is when the surgeons go in and there's no tumor left at all. It's very rare that that happens. But Mike, do you think we know why we're not able to cause more pathologic complete responses? I don't know the answer.
No, no, and we don't even know the answer of sometimes how those studies that show that there's better pathologic complete responses do not translate a lot of times into survival benefit. So there's a lot of things that we don't know about cancer, and specifically here gastric cancer, but there's so much under the surface of what we see. That, like, people think, and this is actually something that it's important that a lot of times when I talk to patients and I discuss what the pathologists call pathologic complete responses and all that, they think that the pathologists, when they receive, let's say, a stomach or an esophagus partial gastrectomy or something like that, that the whole piece, that every single bit of it, it's looked under the microscope. And that, unfortunately, it's not the case. And that could be part of the reason that we just, that it will be impossible for, and maybe in the future, I don't even know if artificial intelligence will be able to solve this type of things, but most of the times the pathologist looks first at what they call the gross. The gross means that they looked with their eyes, an area that they looked abnormal, they make cuts, and out of those cuts are the ones that they looked under the microscope, and then they take some areas that don't look abnormal, but they're just bits and pieces. It's not everything under the microscope. It will be impossible to go through all that. But why do we get more responses that sometimes don't translate, and why don't we get even more responses with the chemo? That's the holy grail of oncology.
Yeah, I completely agree. We are very bad at predicting sensitivity to any given chemotherapy, FLOT included. Rutika, I'm going to spin the question a little bit to you because it's another common clinical scenario about, patient comes in to review their pathology after FLOT, and it says, no or minimal pathologic response. How do you talk through adjuvant thoughts around that scenario, which happens all the time?
Yeah, that's a very tough question that gets posed. Unfortunately, we really don't have data from the study to say what happens when patients don't respond to treatment as you would expected. There's also not much data that has been published as to what would happen, what are the outcomes if patients didn't end up completing their adjuvant treatment. So those are two common scenarios that I get posed with. One thing that my experience has taught me, especially with treating so many gastric cancer patients, has been that although it may have not caused that visible effect pathologically, there is still some effect on the microscopic disease. And I typically would try to convince patients, barring no contraindications or intolerability to treatment, to try and complete the adjuvant course as much as possible to try to get rid of some of that micrometastatic disease.
Yeah.
One thing that it may come in the discussions in the future, and we had that discussion this year in ASCO GI, was the possibility of using everything up front, the total neoadjuvant approach, similar to what we do in rectal cancer. And I think that patients are going to be faced with that option by some of their local oncologists, which obviously has not been studied that well. There was just like one trial that was reported of giving everything up front, but it even calls the question of, like, when do we take a look to see that the chemotherapy is doing the trick, or should we just go blindly and try to give everything up front? But this is something that I have the feeling that over the next few sessions with patients, we're going to be getting those type of questions, that they're going to be offered everything up front.
I mean, I do get asked that question, what if I try to complete more of the courses up front? And again, that's always a timing issue, right? Your number one, your surgeon also has to be bored on that to kind of ensure that they're okay with delaying surgery for a few additional weeks. And then what would be your time point where you'll do another look through to make sure that the patients are responding to treatment? So one thing I've kind of used is if their cancers are PET avid, which means on the PET scan, it does light up. If the tumor does light up, then I'd repeat their PET scan maybe after 3 rounds. And if it's showing response, then I would continue for 3 more rounds before sending them to surgery, provided that the surgeon is on board. But you also don't want them to have significant bone marrow suppression, which makes it much harder for them to recover after surgery. That's the downside of doing a lot of these treatments up front too.
Yeah, I agree. Very, very much. I think us oncologists hear it loud and clear from patients that this is an area we need to study and investigate and try to have answers for these questions, since we don't. In general, you get one shot to cure, and we want it to be the most effective therapy. I see 2 last questions, and I know I want to be respectful of everybody's time because we got 5 minutes. But I'll go to you, Mike, and then to you, Rutika, real quick. What is your typical surveillance protocol at your institution for someone who has an R0, gastrectomy? In this case, has a very good nodal retrieval, but in general, after an R0, how do you follow people?
Yeah, this is something that people don't understand, how we have not been able to figure this out. And it's funny to think that, like, I do all GI oncology, so I do still a little bit of even colon cancer and things like that. And just this year, we're still discussing how do we follow up patients with colon cancer after they have curative surgery. And we still have not been able to clear the water there, even though that there's been like 3 studies. Gastric cancer is much more rare. We learn mostly from our Asian colleagues of how to follow up here. To the best of my knowledge, I don't think that there's an actual randomized trial of follow-up, and the Japanese have better guidelines. So we really do our best to kind of like look at certain imaging studies at certain frequency where we get the gut feeling. We're starting to scrape the water of minimal residual disease, which is probably a full topic on its own, and I won't even open that kind of worms that much. But the truth is that the answer to the question is like a complete, what's your gut feeling of when do you need to do it? So I look a lot at the clinical picture of the patients. That being said, it's a very difficult one because a lot of the patients with gastric cancer are going to lose weight because of the surgery that they go through. Because at the end, you have to think that to a certain level, the surgery for gastric cancer is very similar to a gastric bypass. It is a gastric bypass, and the patients are going to lose weight. So saying, oh, the patient is losing weight, I need to do scans more frequently. I don't know. I don't think so. But we kind of like follow a little bit of clinical intuition, but with no evidence.
All right, so you got an easy out on that one. Rutika, what do you do? How do you follow these people? I mean, I agree. I don't think that the NCCN doesn't even offer us a very clear guidance on this.
Right. I mean, every 3 months for the first 2 years, and then every 6 months following that up to 5 years, or sometimes even longer. Most of the patients, want to stick around for surveillance, for a longer duration of time. So that's kind of my timeline that I've used. But again, as symptoms, I typically tell my patients any of the alarming symptoms, weight loss, sudden weight loss, change in appetite, abdominal distension, call us immediately, and then we'll see them sooner.
Yeah, I agree. So I assume you're referring to pathology report that shows vascular invasion or lymphovascular invasion or some term like that.
Yes, that's correct. Thank you.
Yes. When pathologists, cut things out, they look at it under the microscope and they describe a bunch of patterns of stuff. And one of them is tumor cells extending into the tiny little blood vessels or tiny little lymphatic channels that are, of course, coursing through every single organ in the body. You have these little capillary kind of things for lymphatics and blood vessels. And really, what we're basically looking for is is there any features of the tumor that make us think that it has a higher risk of having gotten out of the stomach to other areas? Like, you know, positive lymph nodes are probably the strongest risk factor, but other things like lymphovascular invasion and perineural invasion can be associated with slightly higher risk, but they're all trumped by lymph nodes and the T in the end stage. And so it's a feature, it's described, it's common. I don't personally put a lot of weight on it when I'm reviewing the pathology reports for stomach cancer resections because there's other more important details. I don't know, in the last 2 minutes, Rutika, to you, and then to Mike, if you weigh this one very heavily.
The only case scenario where I weigh that heavily would be NT1 disease, and endoscopic resections are being considered. So if there is lymphovascular invasion, then the endoscopist or the gastroenterologist will probably shy away from endoscopic procedures and refer them to a surgeon. But otherwise, I agree with Sam. I tend to believe that there are cancer cells in your body. Sometimes your immune system will take care of those. And sometimes if they don't, then you unfortunately end up with a recurrence. So lymphovascular invasion does not always imply that there will be lymph node involvement or metastases.
Hi, very quickly, I just have a question. Has had multiple CT scans, and and obviously we're trying to get into these clinical trials, and they want measurable disease, but a lot of the CT scans don't give us that measurable disease. And one thing that I've been back and forth with our oncologist about is that he has no measurable lymph nodes. Have you ever encountered that before, where there's been no measurable lymph nodes on any CT or PET scan, but they're saying there's cancer, but it's probably not? Like, he has something called mesenteric edema. So could cancer hide within scar tissue? Could it hide within edema and not affect the lymph nodes? Kind of a
Mike, I'll give you a crack
study
at this
question
one,
there.
and it is 9 o'clock, so if anybody wants to drop off, nobody will be offended. But Mike, you can have the first crack at that one.
Yeah, no, definitely. So we use very strict criteria because we have to have reproducible data. So we use something called RECIST criteria, which is response criteria in solid tumors. And for us to be able to measure lymph nodes, we use what we call the short diameter. Most of the lymph nodes are like elliptical type of measurement. So the short diameter is the one that has to be at least 1.5 centimeters for us to consider them measurable. And we see tons and tons of patients. Lately, on all the clinical trials that we have opened for gastric cancer, ascites, meaning fluid, has been considered measurable. So we have allowed ascites in the latest clinical trials, but I see tons and tons of patients that unfortunately don't have measurable disease and they cannot qualify for the clinical trials. Now, I have to say a quick thing on that regard. If there is a drug that you feel that there's an absolute great option and there's no way to get into any clinical trials, there is this right to try law, and you can ask your doctors if they will allow you to go into a compassionate use protocol in which you can try to get the drug. It requires a center, a physician, and a company to align the stars together to get that, but you can give it a try.
Yeah, I will say also some clinical trials allow evaluable disease, which is slightly different than measurable disease. So I know you had written about a trial at Columbia with FAC and MEK inhibitors that's being run by a friend and colleague of ours, Dr. Moy, and I believe that trial may allow evaluable disease without measurable disease, but it still has to
We're
be
actually
something
going to see him on Tuesday, so it's definitely a little more lenient in his case and everything. So, and we've received Keytruda and Lynparza, believe it or not, in compassionate use as well. So it's definitely the option, but it's frustrating,
It's extremely frustrating, and it's an unmet need that we all know about, and someday we hope can fix. But as long as the radiologist is comfortable, there's something that they can reliably say is better or worse, that usually will meet evaluable, but might not meet measurable. Well, good luck on Tuesday. Tell Dr. Moy hello.
Okay.
And At that note, I think we should close this. Thank you to everybody for coming to this first Debbie's Dream Doctors on Call webinar. And we'll look forward to doing it again sometime soon. Thanks particularly to Mike and Rutika.
So good
Thank
to see you
you.
guys.
Bye-bye.
Thank-
Thank you, doctors, and thank you, everyone.